Very good afternoon. After a very interesting keynote lecture session, we move on to the dorsal spine. And I begin my presentation on dorsal spine anatomy. My anatomy presentation is primarily going to focus on two important surgical procedures. One is pedicle screw fixation, and the second one is posterolateral approaches to the dorsal spine. A dorsal spine, as you know, there are 12 in number from D1 to D12, and they comprise the dorsal spine. The dorsal spine has got the different components like any other vertebrae. It has got a vertebral body, it has got pedicles, it has got transverse processes which are projecting posterolaterally, unlike the other transverse processes in the cervical and lumbar region. It has got bilateral laminae, and it has got a spinous process which is pointed and goes downwards. Now, two important anatomical landmarks our audience should know with respect to performance of pedicle screw fixation. One is the facet joint, and the second is the pedicle. Now, if you look at the anatomy out here, this is the facet joint of a dorsal spine. The facet joint orientation is coronal here, unlike the lumbar spine where it is sagittal. This is the facet joint. The facet joint is formed by the supraarticular facet of the inferior vertebral body and the inferior articular facet of the supravertebral body. They are facing each other in an anterior-posterior fashion, and the angulation and the orientation here is coronal. And as far as the pedicle is concerned, this is the pedicle. Pedicle is the part of the vertebral body column which joins the vertebral body with the posterior complex. In the thoracic spine, as you can see, there are three important aspects that our audience must know. First of all is the craniocaudal orientation. Second is medial lateral orientation, and thirdly the diameter of the pedicle. First of all, we'll look at the craniocaudal orientation. Now, this is the level of D1, and this is the pedicle. From D1 downwards, you can see that the pedicle has a superior to inferior angulation. It is located obliquely if you look from the side. It is not horizontal. And this obliquity, it continues until the level of D10 and D11, where it is more or less horizontal. So this is something that you must know. The second aspect is medial lateral angulation. Now, for medial lateral angulation, I'd like you to focus on the D1 vertebra here. This is the pedicle. This is the plane of the pedicle. As you can see, the pedicle is attached to the vertebral body at around 25 to 30 degree angle. And this angle is present at D1. As you go down the spine right up to the level of D2, what you see is this medial angulation, it becomes progressively decreased. And at the level of D12, this angle is either 0 degree or slightly convergent around 5 degrees. So this medial lateral angulation has to be understood. And the third component is diameter of the pedicle. The diameter of the pedicle is thickest at the level of T10, T11 and T12, which is known as the lower dorsal spine. It is almost similar to the lumbar spine. On the other hand, in the upper dorsal spine, that is from T1 to T3 or sometimes T4, it is next thickest. And it is thinnest at the level of mid dorsal spine from T5 or T4 right up to T9. So the pedicle diameter is thinnest in the mid dorsal segment, it is thickest in the lower dorsal segment, and it is probably intermediate in the upper segment. So these informations are important for you to know. Now, what are the entry points for pedicle screw insertion? As I said, it will be very easy for you to understand if you divide the vertebral column into three segments. The upper three and the lower three, that is upper third and the lower third, they have got similar entry points, and the middle segment has got a similar entry point. So I'll first explain for the upper third and the lower third. Now I'm right now working on D11 vertebra. This is the transverse process which is projecting posteriorly and superiorly, and this is the facet joint. Now, first of all, you need to expose the facet joint. The facet joint exposure is slightly difficult and requires experience. The best way of doing this is you need to find out the laminospinous junction, follow the upper border of the lamina until you reach the joint. Similarly, if you start tracing from the transverse process and if you trace it retrogradely, you will reach the facet joint. And once you reach the facet joint, you need to understand that the joint is coronally oriented. So first you will find the inferior articular process of upper vertebra, and below that will be the supraarticular facet of the vertebra that you are searching for. So to expose that, you need to remove the articular capsule here, and you can insert a dissector and apply some kind of local distraction of this sort. Sometimes it may not be easy. So the best way of doing this is drill around 3 to 5 millimeter of the inferior articular process here. Once you drill it, the bone that you see is nothing but the superior articular process. So exposure of the superior articular process is very important. Transverse process we have already exposed. So what are the landmarks? The landmarks, as I said, are different in different areas. I'm now focusing on the lower spine, lower dorsal spine. You see the transverse process, you draw a line right through the center which bisects the transverse process. You draw another line which goes by the lateral side of the superior articular facet that you have already exposed. This line is actually going through the pars interarticularis. So the point of intersection of these two lines is the point through which your pedicle screw will go. The same principle applies to the upper dorsal spine. You find the joint, facet joint, by the technique that I have mentioned. You see the superior articular facet, you will draw a line just lateral to the superior articular facet. You draw another line that bisects the transverse process, and the point of intersection of the two is your screw entry point. Now let us see how the things become different in the mid dorsal segment. In the mid dorsal segment, the entry point, it migrates cranially and slightly medially. Now how it is different? Rather than drawing a line through the center of the transverse process, you draw a line that goes to the upper third or the upper border of the transverse process. And the vertical line here is the line that comes through the center of the superior articular facet rather than the lateral margin. So the point of intersection, you go just 2 millimeter lateral to this, and this is your entry point for the mid dorsal segment, that is from T4 to T9. So once you have identified the screw entry side, the subsequent entry will be determined by two other factors that I've already explained, that is craniocaudal angulation in sagittal plane of the pedicle and mediolateral angulation, as I've already explained. Now the pedicle screw can be placed either using the anatomy of the pedicle, which is called anatomical entry, or sometimes it can be placed in a more horizontal fashion using fluoroscopy. It is said that the horizontal insertion has got a better insertional torque and better pull-out strength compared to anatomical screw entry. Now sometimes it is difficult to place a pedicular screw. In that situation you use another technique called in-out-in technique, or the parapedicular technique, or the extrapedicular technique. What you do here is, rather than choosing one of these points that I have already mentioned, you go for the top of the transverse process, or sometimes the gap between the transverse process and the rib, which is out here. You follow the plane in between, and you go and hit on the side or on the base of the pedicle. Thereafter entry is inside the body. So here you are bypassing the pedicle and you are going right into the vertebral body. This technique is useful in situations where the pedicle is thin, or the pedicle has fractured, or sometimes in vertebroplasty and kyphoplasty, where the aim of the surgeon is to direct the needle to the center of the vertebral body so that the cement that you are putting in gets equally dissipated on both the sides. Now this finishes our pedicle screw fixation part. Now we come to the paramedian approaches. Now as we all know, dorsal approach to the vertebral column doesn't give us much exposure ventral to the spinal cord, and there is not much room to retract the cord either. So you need to either go anterolateral through thoracotomy, or you can approach the spine through the posterolateral approach. So there are three posterolateral approaches that you should understand. One is transpedicular approach, that is go through the pedicle. What is costotransvasectomy, which is slightly lateral than the transpedicular. Here you go through the head of the rib and the transverse process, that is why it is called costotransvasectomy. And there is one more lateral approach which is called lateral extracavitary approach. Here the cavity we refer to is the pleural cavity. So you go lateral to the transverse process but medial to the pleural cavity. So let us see the bony landmarks. In transpedicular approach, you remove the pedicle. How do you remove the pedicle? You just have to drill the supraarticular facet, ipsilateral lamina and transverse process, and this will give you the pedicle. You drill the pedicle and you reach the vertebral body. You can imagine the exposure gained here is only minimal, and only some localized pathology of the lateral vertebral body can be addressed. If you need an exposure more than this, you have to go slightly more lateral, and that is called costotransvasectomy. Now to understand that, you have to first understand the orientation of the rib that is attached here. This is a D7 vertebra, so the 7th rib will come and it will attach at 2 points. At the transverse process, it is called costotransverse joint, and to the vertebral body known as the costovertebral joint. So this is how a rib is attached. In costotransvasectomy, what you do is, you expose around 6 centimeter of the rib, you remove the rib by disarticulating the rib from here, from the transverse process and the body, and you remove the head of the rib and proximal 6 centimeter, taking due care not to injure the pleura. Then you remove the transverse process and pedicle and lamina if you want. So this gives you exposure more lateral, and your target will be more medial when you are doing costo-transvasectomy. So it gives you more ventral exposure compared to transpedicular approach. But in certain times, you need more exposure. You need more than 180 degree exposure. In that situation, you have to go more lateral. So that for that, we need to go lateral extracavitary approach, which is a very good exposure from T4 downwards. Above T4, the presence of scapula limits the lateral exposure. So what is done in lateral extracavitary approach is around 8 to 10 centimeter of the rib, which is more than the rib that you have removed in costo-transvasectomy. So around 8 to 10 centimeter of the rib is resected by mobilizing the erector spine immediately. After removal of the rib and by preserving the intercostal vessels, this is very important. The intercostal vessel has to be preserved in this process. You also remove, along with that portion of the rib, the transverse process, the pedicle and ipsilateral lamina. So this will give you a more lateral exposure, and you can decompress around 270 degrees of the spine from this approach. And if you combine it with costo-transvasectomy on the opposite side, you can get nearly 360 degree exposure. Now this exposure gives you an excellent exposure, and you can put in a cage through this opening that you have created, and at the same time you can also put in pedicle screws. So this is how this posterolateral approaches can come in handy, and it can be a single stage procedure for some of these pathologies. So with this, we come to the end of the anatomy section of dorsal spine. Kindly continue with the rest of the lectures. Thank you.